everyone, and thank you for joining us for today's CAI webinar. I'm Nicole, a continuing education coordinator for the Collaborative for Accountability and Improvement, CAI for short. Before I introduce today's speaker, I wanted to cover a few housekeeping items. Please submit your comments into the chat or questions into the Q&A at any time, but we will hold all questions to the end and I'll help facilitate them to today's speaker. So with that, we are thrilled to welcome Dr. Evan Benjamin. Evan is Director of Community Innovation at Ariadne Labs, a joint center of healthcare innovation at Harvard School of Public Health and the Brigham and Women's Hospital. He is Associate Professor of Medicine at Harvard Medical School and Associate Professor of Health Policy and Management at Harvard School of Public Health, where he teaches healthcare systems, quality improvement, and patient safety. Dr. Benjamin was co-chair of the Massachusetts Alliance for Communication and Resolution After Medical Injury, MACRME, as many of you may know it, a 6-hospital alliance in Massachusetts to promote communication resolution programs. His research focuses on the impact of CRP on patient and provider experience, as well as outcomes of cost and patient safety. At Ariadne, Evan helps lead projects and programs to design and scale solutions to improve healthcare delivery that relieve suffering and save lives globally. His work to improve transparency and reliability in healthcare has been recognized nationally. Evan also co-founded PACT, the Pathway to Accountability, Compassion, and Transparency, which focuses on implementing highly reliable harm response programs. PACT is currently accepting applications for the next wave of the collaborative. So if you're interested in learning more about successfully implementing highly reliable harm response programs, don't hesitate to reach out to us. And with that, I will pass it off to Evan.
Oh, thank you so much, Nicole. And it is a real pleasure to be here. I'm very privileged to be able to work with CAI, the Collaborative for Accountability and Improvement, both here as we are going to have a talk today about innovation and scaling improvement, but also with our work around PACT. Ariadne has partnered with CAI to launch the implementation program that we call PACT, and we're going to share with you today some of the learning that we've had. I'm going to talk a little bit about improvement, and I hope try to entertain you in a way to think about how do we even make improvements in healthcare? And then I'm going to apply that to some of the work that we've done in trying to help systems implement communication and resolution programs. So for those of you who aren't familiar with me or Ariadne Labs, just a quick background. Ariadne was founded about 10 years ago by Dr. Atul Gawande. It was founded to be a joint center of health system innovation. We exist at the Harvard School of Public Health and at the Brigham and Women's Hospital, really at that intersection between public health and healthcare delivery. The mission of Ariadne, though, is to really look at the gaps that exist in healthcare. We call them implementation gaps or no-do gaps, where we know what we should do, we know what healthcare should look like, yet in practice, there's a big gap, a big chasm of actually achieving what we know we should do. Our goal is to design simple and scalable solutions that can be spread to improve people's lives everywhere. So just a few definitions. Today, we're going to talk a little bit about innovation and improvement and scale and spread. So when I talk about scale and scaling up, it's really trying to take a small test of change that you may have started in an improvement work where you're trying to make behavior change, you're trying to make process changes, and you've done it at a very small scale. And now you're going to scale it up. You're going to have others do it. This could be starting perhaps at a one particular medical unit, and then you're going to start scaling it to other units. Spread, we talk about spread, we're usually talking about taking an improvement across two disparate organizations or even geographic areas. It's really the taking up of an innovation or the taking up of an improvement and spreading it widely. So scaling, think about scaling as this, it's learning from your small tests. You do these small tests of changes that they're based on hunches and theories and ideas. You take them through PDSA cycles that you work on, and you roll that PDSA up the hill, if you will, to actually come down with a process that you believe now could be scaled up. So scaling is taking those small tests of changes, taking and learning from your PDSAs and taking it to a larger scale within your organization. When to do this becomes a big decision, okay? And we think about this a lot. If in fact, as confidence grows of what you're doing, the new process that you're doing is actually working, and you believe that there's readiness in the organization. In other words, what does staff think about it? What does leadership think about it? Is it getting the results? That's when you can really begin to do a large scale. And I break this down, I think about it this way, that if you have high confidence that the change that you're working on actually leads to improvement, and you've seen it, and you've seen that the cost of failure is actually not that big, you've done these small tests of change, and you believe that the staff, the readiness in the organization is very much in agreement with this, you really can move to full-scale implementation. However, if you're unsure, if you think the staff may be indifferent, you may want to just do a larger scale test. If the cost of failure is very large, it could be a smaller scale test. And so this is just a framework to think about, when do you scale? And what it means, and we're going to get into this, is really assessing the readiness in the organization and understanding the confidence that you have that what you are actually doing does work. So let me talk about this through a couple examples. You know, the real question is, we've seen some innovations and improvements spread really quickly, and others very, very slowly. And let me take you through two contrasting examples. The first is the innovation of anesthesia. In 1846, the Boston surgeon, Henry Bigelow, was approached by a local dentist who insisted that he had found a gas, William Morton, that could render a patient insensible to pain of surgery. And famously, on October 16th in 1846, Morton administered his gas through an inhaler to a man who was having a tumor removed from his jaw. The patient woke up, had the tumor removed, and said that they felt nothing at all. So Bigelow was thrilled by this. He wrote it up and published it in what was called the Boston Medical and Surgical Journal. It's the predecessor of the New England Journal of Medicine. And in November, so this is just 1 month later, in November of 1846, it was published. By February, so talking 5 months later, of 1847, ether, as this gas was known, was now used in all of the capitals throughout Europe and the United States. And within 5 to 7 years, ether as an anesthetic was used really in almost every Western hospital. Now, it sounds simple, but actually there were forces of resistance to this spread. You know, there were physicians who actually felt that pain was the necessary part of the healing process, and you actually needed to have pain, and we should not be having anesthesia. There were members of clergy who also said, you know, it's God's will that their pain is part of the living and healing process. Yes, but within a few short years, most of these objections were overcome, and anesthesia really spread very quickly. Now, contrast this with anti-sepsis work that was going on. In the 1860s, Joseph Lister was thinking about the infections that existed in all his surgeries. Pasteur had already laid the foundation about germ theory, and Lister actually heard that in a nearby town in Carlisle, in England, they were using carbolic acid to decrease the smell in their garbage pits. And Lister theorized that what was happening was that bacteria was being killed by the carbolic acid. He fashioned a surgical approach using carbolic acid to do two things: to soak and disinfect the instruments of surgery, and then also to have a fine spray that you can see here in this artist rendering over the surgical field. He saw that in a very short amount of time, he reduced surgical infection and mortality by over 50 to 60%. And like Bigelow, he published this. He published this in the Lancet in England in 1867. However, unlike anesthesia, the antisepsis work to actually decrease infections and mortality did not spread. In fact, 20 years later, there was still very little antiseptic work being done in ORs. Surgeons still weren't washing their hands. They certainly weren't using any spray in the operating room. And it took over 30 years for this antisepsis work to be accepted to actually have antiseptic operating rooms. So what's the difference here? When you think about why did one spread and why not the other? Well, first, at face value, think about, was there a difference between the incentives between these two? Well, not really. If you think in terms of financial incentives, in fact, if in fact you survived your surgery through antisepsis, which was really the impact there, you could actually pay the surgeon. So if anything, antisepsis financially was a bigger incentive. Was there a difference in terms of complexity? They both added complexity to doing surgery. Anesthesia, actually, you had to add a new person, an anesthesiologist, to make sure the patient was receiving the proper gas. And you can see with the spray and the disinfection of instruments that it added complexity. So they both had complexity. What about impact? They both had actually significant impact. One is, not operating on someone who's flailing about, and the other had a significant impact on infection rates and mortality. And so, there's subtle differences that we'll come back to, but what the idea here in general is that for the surgeon, life was a little better with anesthesia. And it was really the short-term effect that the surgeon was seeing that I think led to some of the immediate spread. But there's a lot of other subtleties, and I'll share with that in a more detail in a minute. So we actually believe at Ariadne, where I work, that the fundamental problem in healthcare is a failure of execution. We know what we should be doing. We know what is the right thing, that healthcare should be safe and timely and effective and efficient and equitable and patient-centered. And yet we don't live up to those standards. And it's not because we don't have the knowledge, it's because we don't execute. We don't have the systems in place to execute. This data that you're seeing here comes from the Lancet Global Health Commission on high quality care. And it's actually showing that globally now, there are more deaths due to poor quality of care than actually due to insufficient access to care. So it's really execution and quality that is the biggest problem of healthcare delivery today. I think about improving performance, and how do you know when you have a good idea and then you want to change behavior and you want to implement it? I think we talk about these in terms of stages. Stage one of improving performance really is around, we tell people, we educate them, right? We do CMEs and education, and we said, you should do this, right? You should do X. And what we see is very widely variable performance. The change that happens is much smaller than we expect. In stage two of improving performance, it's more when we have mandates in place or incentives, things like pay for performance, or we have regulation in place. And this is more moving from you should do X to you must do X. And this has actually been pretty disappointing in terms of adopting new innovations. We see a modest improvement in performance. Stage three, which I think where we need to be, is really where you're systematizing the innovation, right? You're systematizing X. You're using checklists, defaults, data feedback loops, opt-outs, principles from high reliability, understanding workflow, using systems of care. And that's really when you begin to see consistent improvement in performance and high reliability in the changes that you're trying to make. So remember these three stages of improving performance. At Ariadne, we think about the scale and we think about the systems. We have an arc of innovation where it's in three phases. We spend a lot of time in design, and that's really designing the system, learning from the system. What about the system works and doesn't work, and where does it need to be changed, and how does that change happen with high reliability? Then we test it. We test those changes that we anticipated that would result in improvement. And if that's successful, we will then move to a spread phase where we're really helping others take the tools that we designed and implement them. And you'll see an example of what we've done for communication and resolution programs, where we've designed tools to improve the implementation of communication and resolution programs. We've tested those tools, and then through our work, such as the PACT Collaborative, we're spreading that work. But getting back to understanding why do some innovations catch on and others don't, this is our design and our test. I don't have to go through the details here. We believe that you need a number of different aspects. On the left here, you need a good tool, right? You need an innovation, and that could be whatever you're doing to try to improve care. It could be surgical infections, for instance, that you're trying to improve. But it's not only the tool, you have to put that tool in place with what we call an implementation pathway, right? You need to put it in to understand the workflow using high reliability principles. And then you need to do that in a ready environment. And what we mean by a ready environment is an environment where the staff is capable and motivated. If you can have a tool that you know works, if you can have an implementation pathway, if you can do it in a ready environment, you can then see the effective adoptions of process changes, which results in better delivery of care, which results then, of course, in better patient outcomes. And those outcomes could be anything from patient-centered experience to mortality rates. Let me give you an example of this work. Early on at Ariadne, it became apparent of the international problem of surgery. And that was that the incidence of death or complications following surgery was exceedingly high, over 3%, where 1 in hospital deaths was associated with an adverse event that arose from surgical care. These were from surgical infections and other complications. The feeling was over half of them were actually preventable. And so the World Health Organization came to Ariadne and said, could you help us solve this problem with surgical complications, infections, and mortality? And at the time, Dr. Gawande took on that challenge. And they took it through this design phase to say, let's understand what the problem is, see what we could design that could help. And then we'll test it, and then we'll see if we could spread it. So what was designed was the safe surgery checklist. And this went through a number of different iterations. The checklist is a very simple tool. It's 19 reminders on a checklist at 3 pause points: before the induction of anesthesia, before the skin incision, and before the patient leaves the OR. Basic things that need to happen, but clearly there was a no-do gap, because when we studied were all of these 19 things being done around the world, we saw huge gaps in implementation. Behavior just was not there. So the tool was designed and went through a number of iterations, and then it was tested. And it was tested in 8 sites globally. Some Western high resource settings like Seattle, Toronto, and some middle-income countries, and Amman, Jordan, and also some low resource settings in the Philippines, in India, and in Tanzania. And this global test of using that checklist and was done with an implementation pathway. The implementation pathway was coaching, showing people how to use the checklist, helping them incorporate it into their workflow, getting data on what part of the checklist was actually being done, and giving them feedback on that. When that was done, the results from that test, there was a nearly 50%, a 47% reduction in overall mortality from surgery in this 8 multi-site test. You can see other complications were reduced, 36% for any complication, 45% reduction for surgical site infections. But what's really interesting and what's important for us to think about today is over the years after this first test, we've implemented the surgical safety checklist in many different settings. And what we found is the relationship between how intense our implementation support is. In other words, what are you doing to help people, to coach, to use data, and the results, how much of a mortality there was a direct relationship. So for instance, you see here a checklist adoption on the y-axis on the left, and then on the right is sort of a surrogate for the number of touch points. So the trial that I just mentioned, there was a 47% reduction in mortality. There was weekly implementation support, weekly review of data, going over the checklist, coaching, feedback. That was the most reduction that was seen. If you scale back the number of touch points, Scotland and Norway had studied the implementation of the checklist, and there was regular feedback. It was just less frequent than weekly. It was towards monthly feedback. And there they saw between a 26 and 43% reduction in mortality. In Virginia, it was done in combination with team training and with support that was more quarterly, and there was about an 18 and 24% reduction. In South Carolina, this was just about 6 years ago, we went down to South Carolina. All the CEOs in the state, all the hospitals agreed they would implement the safe surgery checklist, but here was very light touch support. There was some implementation, there was some coaching, but it was nothing like the weekly support. And even there was a 22% reduction in mortality. Now, that was just 6 years ago here in the United States. So significant impact, but less, of course, than the trial. And contrast that in Ottawa, the Canadians actually said, boy, this seems to be working. We're just going to mandate every hospital in Ottawa needs to use the checklist. They didn't have any coaching. They didn't implement it with any high reliability. They didn't use data feedback loops. And they saw actually no impact. There was a 0% reduction on mortality. So you see a big difference in the intensity of the implementation and the uptake of it and the success of the tool that was developed. So it really began us on this path to try to understand, why is it that some things, one, spread, and two, what is it about the implementation that makes some innovations successful and others not? So it allowed us to begin to think that when you do improvement work, when you're trying to actually implement at scale, it's more than just having a good tool. You really become what we call a social change catalyst, right? You really need to build the cause. You need to bring all the stakeholders together. You need to have everybody agree upon what is the goal of you're trying to do together, so everyone has buy-in. To select what's achievable. What are the wins that we think we could accomplish together as a group? And then you need to drive demand for what you believe is the tools to get there. You have to raise awareness, you have to build the will, and then that drives the demand to implement the solutions that you have tested. And so being an improver is a big job, right? It's understanding the problem. it's designing the tools to do it, it's creating an implementation pathway, but it's really being a social change agent as well to bring everybody along. And that includes leaders in an organization, to staff, to all the external stakeholders. So at Ariadne, we've done this for a number of different things. We've tested our solutions that we've designed in childbirth, in surgery, primary care, work around end of life, and a lot of work in patient safety, trying to improve the no-do gaps in patient safety. But let me share a story about one of our projects, which has led us down a path to really understand this question, which I started with, which is, why do some innovations spread swiftly and others don't? And that was from our Better Birth program. So the Better Birth program was trying to solve for the problem that, particularly in low and middle income countries, the compliance with known best practices for childbirth was very low. And we came along and said, this looks very similar to surgery. Let's design a checklist, which has now become the WHO Safe Childbirth Checklist. It's a tool, has 29 items, very basic items of, from washing hands to checking the mother's blood pressure, to treating the mother's blood pressure if it's high, to using oxytocin at the appropriate time. And we said, let's test this. We saw in a couple countries it was tested. It was enormously successful to lower infant mortality and maternal mortality. Then we said, well, let's test this at scale. Really, let's move now to a large scale. We know it worked in these small tests. And what was done was a randomized controlled trial, one of the largest ever done in maternal health. 160,000 women in 120 sites in Uttar Pradesh, India. It's one of the poor states in India with a very high maternal and neonatal mortality. And we said, this is going to be one of the best success stories. This was a big trial funded by the Gates Foundation. And what we saw was we didn't have the home run that we thought. In fact, what we saw was varied implementation. There were some sites where there was rapid uptake of the checklist and good implementation and reductions in the outcomes that we wanted. But overall, when you looked at this randomized controlled trial, it all got washed away. And the result was a null result in this randomized controlled trial. This was published, if you're interested in this, it was in the New England Journal of Medicine in 2017. But it really led us on this journey to say, why is it that in some places there was good uptake and good implementation and good results, and others there was not, when we thought we were doing the same thing? And so we began down this journey to say, let's understand a little bit what could cause the variation in implementation. We came up with 4 big challenges, and that's these challenges about getting to scale. The first is understanding readiness for change, right? It's understanding going into a particular site. In this case, it was a hospital in Uttar Pradesh, India, that's doing maternal health. What's the readiness for change? Did the leaders want to take on this checklist? Did the staff understand that there was a problem with high mortality? And did they believe a solution could help? The second challenge was around culture. What kind of culture existed in these organizations? What we found is that organizations that had a strong culture of learning, a strong culture of safety, of transparency, of psychological safety, where you could talk about performance, those were the places where innovations and improvements were taken up more quickly. The third challenge was teamwork. In the places that had better teamwork that we could assess, those were also the places where there was better uptake of the checklist and of improvement in general. And then finally, the fourth challenge of getting to scale is really understanding, is really appreciating at a deep level some of the concepts from the diffusion of innovation, and which I'll talk about in a minute, from Rogers' early work in the 1960s, Don Berwick really helping us to reinterpret those. So these are sort of the big challenges. If you look at any type of innovation, success is possible, though it takes a lot longer than we think. We pulled out a number of different examples here, everything from public libraries, which was, an innovation here in the United States that Ben Franklin started. It took nearly 150 years before every town in America had a public library, even despite of the wonderful evidence. But things like polio eradication, oral rehydration solutions, all of which took so much longer once the innovation was invented, right? Once you had the polio vaccine, you had the idea for car seats in children. Why does it take so long? And on average, you see the 20-year mark and then the 45-year mark. It takes so much longer than we think. And in part, this is because of some of these concepts of getting to the challenges of scale. So that first challenge, readiness, this really comes down to a number of different components. The commitment of leadership is a big part of it. The role that leaders play in making sure that an organization is ready and committed and prioritizing, that becomes so important. The prioritization that they want to actually improve, they want to make X project a priority of their system, whether that's communication and resolution or transparency or surgical mortality. It's that commitment from leadership. We found such a dramatic relationship. But also these other aspects. Is there capacity in an organization? Are they doing other things? Are the staff overwhelmed? What's the culture in terms of improvement in the organization? And is there capability to do improvement work? Can you do measurement? Can you do feedback? So this is all part of readiness that we found with all of these things directly related to the uptake of the solution. The culture work gets even deeper, and that's where the culture of the organization moves sort of along this pathway where organizations understand how to do process design, that have tried to incorporate high reliability and reliability culture that's integrating human factors into their work. So they're thinking along systems. And then are they bringing patients and families along? And there's the culture to bring patients and families along. Organizations that have moved along this pathway also are those that have much better uptake of new solutions and improvements. Teamwork is same. Getting organizations to take up a new innovation is much more effective when there's good teams. And we've seen over and over again that teams are just more effective than lone actors. When an individual is leading an improvement and it's all led by one person, you get some acceptance, but it's really when the team together is working simultaneously. And so teams in healthcare face lots of challenges, and it's all part of the systems that we need to create. Our team members are very separate in time and space. Team members lack visibility. They don't have good reporting on performance. And so we have a lot to do to help support teamwork. But we know when there is good teamwork, there's also better improvement work. And then finally, this fourth challenge of understanding the science of diffusion of innovation really comes down to a deeper understanding that Everett Rogers started this work in the 1960s, the last edition of Diffusion of Innovation in 2003. And then really I credit Don Berwick a lot for really helping to bring this to light for healthcare, to help us reinterpret the diffusion of innovation, and understanding that when you have something that you're trying to innovate, you believe this is a good idea. It could be a checklist. It could be a CRP approach, that the people who have to implement it, they all have their own perceptions about it, right? They're wondering, What's the advantage of this? How does this compare to what we're currently doing? Is this going to be really complex? We all know that in the middle, the attributes of adopters vary dramatically. There's some places that have innovators. They want to do everything new. They raise their hand. Let me, I want to try that. And that there are others who are much more conservative and are waiting for others, the late majority and the laggards, to implement and see what else others have done before they implement. And then the organizational contextual factors. What's the incentives at play? What's management? How are people communicating? Is it top down? Does it feel more egalitarian? All those play a significant role. And is there uptake? So we actually took all of this work and we developed an assessment. We created a framework for all of this work. And you can see here the framework. It's based on leadership, culture and context, processes, which is really around workflow, measurement, which we found was so important to have good implementation, and then the amount of person-centeredness. How effective was this implementation at bringing patients into it so it's actually achieving the goals that patients would want? And we created this framework, and then we built out a series of questions. On leadership, the questions were around governance and accountability and prioritization. Is there a good governance model for this implementation? Where does the accountability sit within the organization? Is it being prioritized? Is there dedicated resources for it? In terms of culture and context, it's around leadership, setting the norms of expectations. If we want to be a psychologically safe, transparent organization, are we setting those expectations? And is there a local context that we can understand, that there's the implementation team understands what's happening locally in terms of the local culture? In terms of process, it's really around these ideas of high reliability principles, where you're really understanding workflow and you're trying to incorporate something new without creating more work, and doing so in a way that we described as co-creation, was how successfully co-created is something. So it felt like those doing the work actually had a hand in creating it. Those are the most successful. Measurement, as I said, really important that there's good measures for what you're doing and that you can feedback. And then how person-centered is it? Are we incorporating the patient's values into this improvement work? And those are the ones that are most successful. So like all things Ariadne, we built checklists that you could go through and say, answer questions on leadership, on culture, on person-centeredness, on process, on measurement. And then it got to the point where we could now almost predict at the beginning of an initiative, is this going to be successful? Is there going to be uptake of it? So here's just a drill down into the readiness one. It asks these very simple questions. It's really yes, no, right? The problem being addressed is one of our top priorities, yes or no. The third one down, we do not have other changes underway or planned that will compete with this. The fourth one down, staffing issues will not impact the implementation. I will prioritize my time. Staff will have dedicated time. Very simple questions that give us a directional answer. And from this, we can almost predict, will the simple tool, the CRP implementation or the checklist, will there be uptake? So let's just quickly go back to our example. We talked about two examples: anesthesia with its very rapid spread within 5 years around the globe, versus antisepsis with this very slow spread in spite of probably even bigger impacts on mortality. And what was the difference here? So if we apply our framework, we can answer some of the questions. So first is leadership. Well, here, nobody cared at all about antisepsis. Leaders in the 1800s, it was all about just the number of operations that they could have. No one was measuring outcomes. Nobody really cared much about anything but volume and speed that was happening at the time. So leaders were really not on board with antisepsis as much as they were on anesthesia because you could do more surgery. In terms of culture, that was a big issue that was not taken into account. The culture in the 1800s for many surgeons was, the busier you are, there was this, the cloak that they would wear. The surgeons would wear these dirty cloaks. The dirtier it was, the older patient's blood on it, the better, right? It was not about the outcomes that you were going to have. It was this culture that physicians had around, doing their work. There wasn't much of a culture of improvement that was happening at all. In terms of processes, I think, it was very difficult to incorporate for the surgeon the antisepsis work into their workflow. They had to slow things down, they had to scrub, they had to get instruments washed, and it was hard in terms of workflow changes. Even though anesthesia required some additional workflow, it was not as much as we saw with antisepsis. And in terms of measurement, this was years before Codman, at the turn of the 20th century, began having any measurement, right? He had the end results program that started the beginning of the 20th century to measure what did we do and what were the results. There was really very little measurement going on about what happened in terms of mortality or outcomes, and therefore it was difficult to actually show a difference that you would want to do the antisepsis work. And then finally, in terms of person-centeredness, nobody was asking the patients what they wanted in the mid-1800s. So it really came down to that anesthesia was just much easier for a surgeon. They could do more surgeries faster without a flailing patient, without anyone really worrying about the ultimate outcome of mortality or infection. So that if you apply our framework there, you can see some of those differences. We started last year to implement, help organizations implement communication and resolution programs. We built lots of tools and an approach to implementation. We created a collaborative where we brought together 20 health systems to learn about CRP and take tools and be able to apply them. At the beginning of the process, we took this framework and we tried to assess the readiness to see who was going to be successful. It was really helpful to have those initial conversations. So this was from the PACT early collaborative. This was for one health system. And you could see overall, we asked on the readiness survey on leadership, how functional was the team who's going to be implementing? And this was on a scale of 1 to 4. How much commitment and motivation was there for both staff and leadership? What was the assessment of the culture to do improvement work? And what about the ability to actually do this, to implement? We then took this and we broke it down between staff and leaders. And you can see here the leaders are in squares, the staff are in circles, and you can see how they sort of line up. Pretty good around clinical team functionality and commitment, but a big difference in internal culture. Leaders really felt that the internal culture was much better than staff in terms of the readiness to take on something new. And they were pretty similar on ability to implement. So we have, the surveys really get us more detail to show us here in blue is how much is more agreement, and the yellow and orange was more disagreement. And you can see here on this same site that under the question A4, it says there are no changes underway or plans that will compete with this improvement. And you can see that the staff was saying, yeah, I'm not so sure about that. We've got a lot of things underway. And as well as, are there staffing issues? A10 down towards the bottom. Staffing issues will not impact this work. You can see a lot of the staff are saying, we have some staffing issues. And so this was a great way to assess the readiness and really just to begin the conversation. We're about to implement a major change in your organization to do communication and resolution programs. Let's have a conversation about your readiness based on this Atlas survey that we put together. So really helpful to think about this. So I will just say overall, when you're thinking about taking a health system innovation to scale, to spreading it, it is possible. You could do it. You could design good tools. You can test. You can spread. But to get there, you really need to have a good understanding of readiness, as I mentioned, and using our framework has been helpful to understand context, to understand the culture in an organization, to promote teamwork, and to understand diffusion and the challenges that come up. I will leave you with one story, and this is just to finish up. So Lister was, as I mentioned, was really challenged by surgeons would not pick up antisepsis work, right? In spite of the data, in spite of his publications, they would not take up his work. So he began a global tour going around everywhere. He came to the United States, and he was on a train outside of Philadelphia. And sitting next to him on the train was a young man named Robert Wood Johnson. He had just started his own medical supply company. They made adhesive bandages. And Lister tells Johnson about the challenges of surgeons not picking up the antisepsis. And it gives Robert Wood Johnson an idea. And he thinks if the surgeons don't have to do that much differently, if we could make their life easier, if they can incorporate it into workflow, maybe they would start thinking about antisepsis. And it allowed Robert Wood Johnson to invent the first pre-sterilized sutures that were pre-packaged. And of course, that was hugely successful. Robert Wood Johnson went on to form with his brothers Johnson & Johnson, becoming one of the largest pharmaceutical companies in the world. But stemming from this idea that Lister talked about the frustration of spread and Johnson trying to think through it. So I hope you guys learned a little bit about scale and spread today, and could think about it as you're doing your own work, whether that's in communication and transparency or around any improvement that you're doing. And we could pause here, Nicole. We could take a few questions.
Yeah, so please feel free to type your questions into the Q&A or in the chat. We had a few comments come through while you were talking. The first question is, I guess, from Noelle, and she says her organization is migrating to a new EHR, and is just wondering if I can share the slides with everyone. Evan, is that okay with you if I send out the slides?
Oh, yeah, absolutely.
Wonderful. And then let's see, Kathleen had a question about the stats related to poor quality is a bigger killer than insufficient access. Just if that data is still, how that data might change knowing the time gap from when those stats were first taken.
Yeah, that's a great question. That was pre-COVID. That was like 2018 from the Lancet Global Health Commission. I don't think they have re-looked at that data. Mostly that was looking at those no-do gaps, where if we look at almost any of the clinical evidence-based measures, certainly in the United States, we hover still about 60% overall of success, where we know there's evidence behind a particular process, and yet we fail to do it 40% of the time. And then globally, the Lancet Global Commission looked at what they thought was the impact to mortality overall. So that was pre-COVID, and I don't know what that would be today. We could certainly go back and look.
And we had another comment question come in around the timing of anesthesia. Doug was wondering, based in the Civil War, let's see, let me read this so I don't misspeak it. Correct me if I'm wrong, but they don't use anesthesia widely during the Civil War, correct? Been on so many Civil War tours where we have been told that the troops had to endure surgeries, including amputations, without anesthesia. The Civil War was in 1860, so was uptake actually slower?
Yeah, thanks, Doug, for being the historian among us. I'm not a Civil War historian. I will tell you, though, that, in looking at this talk and putting it together, the success of the spread of anesthesia was in hospitals. And so on the battlefield, where probably most of those surgeries were being done, I'm sure there was no anesthesia, certainly at the time. I'm not a Civil War historian, but it's a great question, and it makes me curious to go back and look.
Those were the questions. Does anyone else have any questions? Okay, we have another comment coming. Let's see. When it comes to communication and disclosure, so many of our problems between patients, families, and clinical staff revolve around incidents that do not involve medical errors. Bad outcomes, but everything did the right stuff. From my travels and conversations over the years, I believe so many of these fires could be put out by doctors and nurses being taught communication skills in school.
Yeah, Doug, that's just a great comment. Tom Gallagher and I, who came together to put together PACT, I think couldn't agree with you more. Part of this work is in the implementation of changing the workflow to get to open transparency, communications with patients, supporting patients, supporting providers. It involves not only a lot of changes in the workflow, but it involves support for the people having those conversations. We do training in communication skills, particularly around after a harm event. And we also, as part of the PACT work, have put together some conversation guides, sort of checklists, if you will, to have these conversations. Not perfect, but one of the things we've done is, in working with health systems that really want to get to highly reliable communication and resolution programs, is to make sure that there is an approach to communication, and that training can be, some organizations choose to do it sort of universally, giving everyone some training. Others have moved to sort of a train the trainer model, or a just-in-time coaching model, where a core team has really been well trained in communication skills. And then they work with a provider who's been involved with a medical error or harm to support the provider and to support the communication. So lots of different approaches to it, but I agree that it's a matter of coming up with a systems approach. And that's really what we've tried to do in PACT, is really encourage our health systems to have a systems-based approach to get to highly reliable both communication skill training, as well as the processes to get to good communication and resolution.
Let's see, we have another question from Jody. Is there a time frame for staying too long on smaller scale if larger scale readiness is not showing promise due to so many projects?
Yeah, let me read. Is there a time frame for staying too long on smaller scale if larger scale readiness is not? Oh yeah. So in other words, you don't think the organization is ready, so you're keeping it small. I think it's a risk, but it's important to keep the success alive, right? If in fact, let's say you have one unit which has been super successful, they're achieving the results, but there's no readiness in the organization for spread because of workflow capacity, leadership issues, all the challenges that we talked about. I still think it's important to keep the success alive and keep it going, because ultimately, they can become the beacon. And when the readiness does improve, when there's perhaps less resistance elsewhere or more capacity, people will see that as a model. So in my experience around improvement, don't give up and keep those successful small scale projects going. Do
we have any additional questions or comments for Evan today?
Well, I have to say this has just been a lot of fun. It was really fun for me to put this together, to think about scale and improvement. And I hope you all were entertained and got to take a little bit home for you. Please reach out to us here at CAI or at Ariadne if you want to hear more about getting to highly reliable communication and resolution programs. That's what we're doing. We're trying to think about scale and trying to change the way we all respond to harm. So please reach out to us if you want to learn more or enroll in our collaborative this fall, which will be kicking off.
Thank you so much, Evan, and thank you all for joining us. Keep an eye out for an email from the collaborative, and I'll share the slides from today's presentation along with some more information about the PAC collaborative. So thank you all so much and have a great rest of your day. All right, bye everyone.